The following podcast is part of a certified educational activity titled Achieving Next Level Care in AML, Conversations on Targeted Platforms, Emerging Immunotherapies, and Implications for Precision Medicine. Access the entire activity and complete the post-test at peerview.com/MQE860. Downloadable slides and practice aids are also available.
Good afternoon, and thank you for being here. We're glad that we have a full house and that we have an enormous amount of people live streaming. So I'm Sergio Geralt. I'm a professor of medicine at Weill Cornell Medical College and an attending physician in the adult BMT service. And I'd like to welcome you to our program called Achieving Next Level Care in AML, Conversations on Targeted Platforms, Emerging Immunotherapies, and Implications for Precision Medicine. So today we am joined by my colleague Selena Luger from the University of Pennsylvania, Pinkel Desai from Weill Cornell Medical College, Dr. Gayas Issa and Tapan Kadia from the University of Texas MD Anderson Cancer Center. So I think many of us remember the time when we would show a slide that says nothing has happened since 7+3. That is no longer the case. And since 2017, we've seen a barrage of new drugs that have now been approved for the treatment of acute myeloid leukemia, both targeted and non-targeted agents. So despite this progress, 39% of newly diagnosed patients and 31% of refractory relapse patients receive no treatment for the disease. Some of it because these patients are frail and hospice and palliative care is properly appropriate. But others, it's because they may not have access to physicians who are actually knowledgeable on how to treat these conditions or do not have access to the drugs that can make a significant difference. So we really think that events like these and symposiums like these are necessary so we can deliver the best care for our patients with acute myeloid leukemia. So our goals for today is to help you understand how baseline patient and disease-related factors can influence personalized treatment selection in AML. We want to update you on current evidence on immunotherapy and emergent targeted strategies for newly diagnosed or refractory relapse AML. We want to equip you with the skills to develop personalized team-based management for AML and provide you guidance on care delivery considerations, including optimized dosing and safety management. There are now multiple resources that you as busy clinicians can utilize to be able to help patients undergo their AML journey. HealthTree Foundation for Acute Myeloid Leukemia provides meaningful patient-to-patient connections, lifetime personalized support and education, and powerful patient data portal. You can scan them or ask your patients to scan them at healthtree.org/AML. They also have, for you as learners, HealthTree University for Acute Myeloid Leukemia, 20 courses and 200 videos, some of them very complex AML topics, 30 AML specialists and faculty. This is an enormous resource that can be accessed anywhere, and it's worthwhile exploring. There's also a HealthTree coach for AML that patients can use to get free one-on-one help by experienced patients and caregivers. There are coaches with specialty expertise, both transplant, financial, treatment, and caregiving, and it's support for all stages of the disease. So without further ado, I'd like to start the program by introducing Dr. Selena Luger, a professor of medicine at the Perelman School of Medicine at the Hospital of the University of Pennsylvania in Philadelphia, and Dr. Pinkel Desai, an associate professor of medicine and the Charles Lillian and Betty Newworth Clinical Scholar in Oncology, the clinical director of Molecular Aging Institute at Weill Cornell Medicine and Leukemia Program in New York City. Please.
Thank you, Sergio. I'm going to start off our conversation today about FLT3 AML. So we're going to start off with a patient scenario. Let's imagine a 55-year-old man with newly diagnosed AML. He presents with fatigue, headache, and dyspnea. His white count's 120,000. He has a hemoglobin of 7. His platelets are 24,000, and he has an ECOG performance status of 1. His creatinine is mildly elevated at 1.4, and he had a cardiac stent placed about 3 years ago. Additional testing shows 90% blasts, And on NGS, he has a FLT3-ITD mutation, a DNMT3A, and a TET2 mutation. And so the things we think about and the questions we ask in this patient is, should this patient be considered for FLT3 inhibitor involvement in induction? And if so, should he then go on to transplant? And which FLT3 inhibitor should we be using? And does the age and/or the mutation type matter when we're making our consideration of what FLT3 inhibitor to use? So where do we get some information to inform this? The RATIFY trial was done when all we knew at that point was that FLT3 mutations, in particular FLT3 ITDs, were of poor prognostic significance. We identified that. We knew that about 1/3 of patients had a FLT3 mutation, and those who had an ITD did poorly. Those who had a TKD had a mutation but did not necessarily have a worse outcome. And we thought that perhaps with transplant we could improve that outcome. We thought that we could identify some drugs that were already available that had some FLT3 inhibitor activity, but there was really not any evidence that inhibiting FLT3 could change the outcome of patients with FLT3 mutated disease. So the RATIFY trial was done to see whether or not adding a FLT3 inhibitor could actually impact the outcome of these patients. So patients were randomized at that point to midostaurin, which was one of the few multi-kinase inhibitors available at that time that had some FLT3 inhibitory effect. Either midostaurin or placebo was the control arm. Patients with ITDs and TKDs were included in this regimen. And as you can see here, and as we all know, the 4-year survival was improved in patients who received midostaurin in addition to standard 7+3 chemotherapy compared to those who received placebo. And there was a benefit both in patients with ITD as well as TKD mutations of FLT3. The midostaurin group had a 74-month median survival, while the placebo group had only a 25-month median survival. And additionally, the best outcome was seen in those who received midostaurin as well as transplant. So this led to the approval of midostaurin and its inclusion in the NCCN guidelines for newly diagnosed AML. But as I mentioned, we knew that midostaurin was not a great FLT3 inhibitor. And so now we've had development of newer FLT3 inhibitors that are both more targeted to FLT3, they're more potent, and actually do not have as many off-target effects. So Quantum First was an evaluation of quizartinib, which is a more advanced FLT3 inhibitor, compared to placebo in newly diagnosed FLT3 ITD positive AML. As you know, this agent was just approved this year, and it was based on this Quantum First data. So Quantum First enrolled patients between the ages of 18 and 75. I should mention that the RATIFY trial was only for patients between the ages of 18 and 59. Quantum First enrolled patients between the ages of 18 and 75 with FLT3 ITD mutated AML. And as you can see here, quizartinib versus placebo, quizartinib group had an improvement in survival, which translated into a 22% reduction in the risk of death. The median overall survival in the difference was 32 months in the quizartinib arm versus 15 months in the placebo arm, so a almost 17-month difference in median survival with quizartinib versus placebo. And when you look at patients under the age of 60, similar to those who were enrolled in the RATIFY trial, as you can see again, quizartinib was improved over placebo, with a median overall survival not reached in the quizartinib arm versus 23 months in the placebo arm. When you look at patients over the age of 60, there is still a difference, 17-month median survival in the quizartinib arm versus 14 months in the placebo arm, but is not as dramatic as it is in those patients under the age of 60. Also, FLT3 ITD MRD clearance at the time of remission was associated with overall survival in newly diagnosed FLT3 ITD mutated AML. This will be presented this weekend by Dr. Alexander Pearl, showing that among patients with a complete remission at the end of induction, the median best FLT3 ITD VAF by the end of consolidation was better in patients who received quizartinib than those who received placebo, and that overall survival was improved in those who had a decrease in their variant allelic fraction and was improved in those who were MRD negative. So overall, in Quantum First, what we saw that adding quizartinib was a tolerable strategy in newly diagnosed FLT3 mutated AML. There were no new safety signals reported, meaning that the QT interval prolongation that we've become used to in FLT3 inhibitors was still present, but was not any worse. There was only seen a small percentage of patients that did not lead to any adverse outcomes, but we're very careful to adjust other medications that may impact the QT interval. The 30-day mortality with quizartinib was 6% and 3% with placebo. 60-day mortality was 7% with quizartinib and 5% with placebo. And in July of 2023, the FDA approved quizartinib with standard chemotherapy induction, as well as, in some countries, maintenance monotherapy following consolidation for FLT3 ITD mutated AML. Now, what about other FLT3 inhibitors? Well, the other FLT3 inhibitor we're all familiar with is gilteritinib, which has been approved only for relapsed and refractory AML. And now there are some studies which are looking at the use of gilteritinib in newly diagnosed FLT3 mutated AML, looking at patients both with ITD and TKD mutations. There have been some phase 1 trials looking at patients over the age of 18, looking at standard 7 and 3 induction, as well as high-dose cytarabine consolidation, adding gilteritinib to FLT3 mutated patients, as well as FLT3 non-mutated patients. And as you can see here, a CR rate in patients who received the combination was 83% by day 56. The majority of patients went on to transplant, and the 4-year overall survival for those patients who were 60 years of age or younger was close to 60%. The median survival of those who were FLT3 wild type was 38.7 months, FLT3 ITD 46 months, and for those with a TKD mutation, the median survival had not been reached. There are currently 2 studies ongoing or completed for which we're waiting for information, which are comparing gilteritinib to midostaurin in FLT3 mutated AML. The PRECOG 0905 looked at an MRD endpoint, and the HOVON 156 trial is testing midostaurin versus gilteritinib induction consolidation with an overall survival endpoint. That study is still ongoing, while the PRECOG study has been completed and data are pending. So what do we know so far about induction therapy for AML? We know that FLT3 inhibitor therapy, when combined with standard 7+3 in patients who are fit and eligible for induction therapy, leads to a survival benefit in patients with FLT3 mutated AML. How do we choose a FLT3 inhibitor? For FLT3 TKDs, midostaurin is currently the only approved agent for upfront therapy, but gilteritinib does have data in the relapsed and refractory setting. For FLT3 ITD, both midostaurin and quizartinib are available for patients who have FLT3 ITDs and approved. RATIFY was only done in patients younger than 60 years of age, and Quantum First included patients over the age of 60. So I'm going to ask my colleagues here, when you have a newly diagnosed patient with FLT3 ITD mutated AML or with FLT3 mutated AML, how do you choose which TKI you want to use?
So I think looking at the data that you described, obviously, because the Quantum First included 60 to 75 group, if that's the patient I'm looking to give intensive chemotherapy, I would prefer to use quizartinib in that situation. Under 60, technically both studies had those patients, and data are available. So I think it's hard to know that it's comparing 2 different studies in apples to oranges, but if possible, I would use quizartinib. However, it depends on what the patients, if they have heart conditions, QT prolongations, all of that also goes into our consideration.
I think I agree with what Pinkel said. I think along the lines of what the trials have done with newly diagnosed AML, with FLT3 ITD, I probably would consider quizartinib-based regimen up front for those who have ITD alone. It's more challenging for me when they have an ITD and a TKD that's existing. I think that, as you mentioned, I think we consider midostaurin maybe not the best drug. And so based on some of the, sort of the single-arm studies that are ongoing, as well as some of our own experience, we actually do incorporate gilteritinib in the front line on clinical trials in our frontline patients with newly diagnosed AML who have sort of both a TKD and ITD, or even those who have TKD alone. But with the sort of availability now of quizartinib, I think that's been our priority in the ITD patients.
Gus?
I agree. I think they said it all.
So I want to be the contrarian here. I mean, in patients over the age of 60, does it really matter what you give? It didn't seem to make a difference. Unless you think about it, I know I'm not going to steal anybody's thunder. The Morpho trial would suggest that maybe gilteritinib would be the right drug for these people, particularly if they're MRD positive. But why didn't we see this impact in patients over the age of 60? Do you have any idea? Was it that they didn't go to transplant, or was that the combination with intensive chemo and a FLT3 inhibitor in these patients is not the best choice? And I know we're going to talk about that later on.
Well, so I think, yes, so the best in data has been, and the best outcomes have been in those under the age of 60. There actually is no midostaurin data in over age 60 in a randomized fashion, although there was some single arm that showed some potential benefit in that patient population. And so we don't really know whether or not we can impact the patients over age 60. But I think you're right. What that perhaps is telling us is that 7 and 3 as the backbone for patients over age 60 may not be what is of benefit with that FLT3 inhibitor therapy. And as you said, we'll talk about that in a little while. So the next question becomes, you've now have this patient in whom you've pursued aggressive therapy. You've achieved a remission in this patient with FLT3 inhibitor therapy and chemotherapy, but he's PCR positive by PCR NGS. He's MRD positive by PCR NGS, and you've decided to proceed to transplant. And so now the question is, what do you do after transplant? Do you consider FLT3 inhibitor maintenance therapy here? And based on the current evidence, is MRD status the best guide for choosing the next steps? Let Dr. Desai.
Thank you, Dr. Lugar. So let us see what the NCCN guidelines say about maintenance therapy currently. For patients who are intermediate risk or adverse risk and have had previous intensive chemotherapy and are in remission and have had some consolidation or no consolidation and no transplant is planned, that's important, oral azacitidine is currently approved as a standard maintenance strategy until toxicity or progression. But if somebody undergoes a stem cell transplant in remission and has a history of FLT3 ITD, here are all the drugs that are listed by NCCN: sorafenib, midostaurin, gilteritinib, quizartinib, most of them category 2B. Patient with a history of FLT3 ITD mutation who have received quizartinib and no allogeneic stem cell transplant is planned, quizartinib maintenance for ITD is recommended by NCCN. So let's see what the data suggests. So the first study for post-HSCT maintenance came from the main study. This was randomized sorafenib versus placebo. And if you look at the 24-month relapse-free survival and overall survival, there was a benefit to sorafenib versus placebo. Same thing for overall survival. There are some caveats to sorafenib post-transplant. Patients can have toxicity issues and tolerance issues, particularly gut toxicity in the post-transplant setting, but it is available. Preliminary data also suggested gilteritinib had similar data, and hence the BMTCN took on the Morpho study. This was a randomized study, and it's important to look through how the study was designed. Patients had to have FLT3 ITD, had to be in remission with 1 or 2 inductions, not somebody who went in remission and then relapsed later. This is people in first CR. These patients had to go to transplant. Any conditioning, donor type, or GVHD prophylaxis was allowed, consistent with the real-world situation. Post day 30, patients who had sufficient engraftment, able to take oral meds, and no acute GVHD that required a higher prednisone dose were then randomized into gilteritinib, 120 milligram daily for 24 months versus placebo. The MRD sampling was taken prior to transplant and also prior to randomization. And importantly, the trial was stratified by MRD, and the definition of MRD here was presence more than 10 to the minus 4. The trial was designed to answer a couple questions. One, what is the role of FLT3 maintenance post-HSCT? And second, are there patients who benefit and do not benefit from maintenance, and at what level of MRD? So if you look at the overall main efficacy outcomes of the MORPHO study, the primary objective was relapse-free survival, and there was the trial didn't meet its own specific endpoint, but the p-value was very close, 0.05. Secondary objective of overall survival was also not met. So was this a negative study? I would say no, and let's think about a little bit on what this MRD testing was and how this was later analyzed. It was known that in patients with FLT3 ITD, via various modalities of MRD measurement, that if you have an MRD value of more than 0.1%, it was a significant predictor for post-HSCT relapse and survival. But there's many different kinds of tests that measure MRD, and it's important to know the difference. So if you look at the standard flow, it's 1 to the 1,000, 10 raised to minus 3. A 12-color flow, 1 in 10,000. The standards of RT-PCR that we many times use at diagnostic purposes for FLT3, it's 10 raised to the minus 5. And what the MORPHO used was a PCR-NGS study, 10 raised to the minus 6 sensitivity. And this is important. If you look at this, the test, this is a two-step assay. First, there is amplification by PCR to increase depth, and then an ultra-deep sequencing. And what are the advantages of this test? One is that it's a patient-specific fingerprint, so it can know what was there and what's persistent, but also because of the deep sequencing flanking the FLT3 gene, you're able to identify FLT3 ITD, if there are varying lengths of FLT3 ITD, multiple FLT3 ITDs, you can actually look at that and figure that out. Although the sensitivities 10 to the minus 6, the quantitative sensitivity is up to 10 raised to the minus 4. So it can distinguish what's 10 raised to minus 3 versus minus 4. But beyond that, from 10 to the minus 4 to 10 to the minus 6, it's really qualitative, so it's present or absent. So if you then look at the MRD positives, if patients were MRD positive, either prior to transplant or at the time of randomization, which is post-transplant, gilteritinib was superior in terms of relapse-free survival compared to the placebo group, and this was actually statistically significant. And at the end of like a 6-year period, about 70% of patients were alive in the gilt arm versus 50% in the placebo arm. While in the MRD negative setting, there was actually no difference. Obviously, there are toxicities, and gilteritinib was associated with some neutrophil and platelet count decrease. These were modified. There were dose reduction guidelines built into the study, but none of these dose modifications or, none of these cytopenias actually impacted any clinically significant events. There was no excess mortality between the two arms. And this is a further follow-up that is going to be presented by Dr. Mark Lewis at ASH this time, where a couple things were looked at further in the MORPHO study, that when the patients on the study were positive post-transplant, 69% had an MRD eradication on GILT versus 44%. So, obviously, stem cell transplant has GBL effect, and there people could turn negative, but it seemed gilteritinib actually enhanced all the efficacy of HSCT. At the same time, what was also interesting was if patients had multiple ITDs, so presence of more than one mutations prior to stem cell transplant, they actually performed much worse regardless of treatment arm. So there's more to come on this, and I would like to highlight this work. So if we are thinking of maintenance strategies, I would like to poll my esteemed colleagues. If somebody is MRD positive after chemotherapy and a FLT3-based regimen, would you wait and give additional therapy to convert them into MRD negative state before proceeding to transplant, or would proceed directly to stem cell transplant?
So I think the most effective way of getting an MRD positive patient into an MRD negative state is proceeding to transplant and not waiting. But these are patients that, have you seen with the Morpho trial and with other trials that we'll discuss, are patients that should be strongly considered for maintenance therapy post-transplant.
No, I agree with Dr. Gerald. I think that trying to get a person into MRD negative remission perfectly prior to transplant risks A, having a morphologic relapse in that time that you're trying to do that because you haven't had effective therapy thus far, and two, potentially adding further toxicity, making them somehow transplant ineligible and not able to tolerate. I think certainly moving ahead with a transplant, hopefully, if eligible, a myeloablative transplant followed by maintenance therapy as shown in the Morpho trial is how I would proceed.
I agree, and I think additionally, we don't know that if you make them MRD negative prior to transplant, you've done that's any better. They're still, I would not trust that as a reason to not give them post-transplant maintenance, because we only know that that patients do well without post-transplant maintenance if they are MRD negative after standard induction and consolidation. If you need additional therapy to get them to MRD negativity, I still think you need to give them post-transplant maintenance in that setting.
And what do you do if someone's TKD positive and they're proceeding to transplant for other reasons of cytogenetic risk, for example? How would...
Well, I think the only agent we currently have for that patient population is oral azacitidine, but that has not really been shown to be of benefit in the post-transplant setting, right? And so the question is there any role for maintenance therapy in the post-transplant setting for the TKD patient, and is there any effective agent? I don't think we have that answer.
And so Charlie Craddock's group is going to do a randomized trial with oral AZA. I do think that in clinical practice currently, I mean, at least in my practice, we are giving them maintenance with azacitidine based on the fact that if in a conventional induction it did show a significant benefit, one would assume that it may continue to show. And I mean, these patients have a relapse rate, as I'll show, of 30% or above, and trying to just hope that nothing happens is probably not in the best interest.
And why not gilteritinib?
So that's an excellent question. I think in this time, I think gilteritinib, gilteritinib would probably be the ideal choice.
I'll just add that maybe clinical trials hopefully will address that question. So I would still think about the clinical trials that are designed as erasers and try to see if maybe MRD negative pre-transplant improves outcomes compared to MRD positive post-transplant with a converting therapy. Dr. Lugar was saying we still don't trust that, so we do maintenance after that. Mm-hmm. But I'm hoping we get therapies that are not toxic, that would still not compromise the chance of transplant, and address that. There may be immune therapies or better targeted therapies.
And is there any downside to giving FLT3 inhibitor therapy post-transplant? Is there any toxicity that we should be worried about in this patient population? Why shouldn't we give it to everybody who's FLT3 mutated regardless, since we have to do this fancy test to figure out whether or not they're FLT3 mutated?
So I think, I mean, obviously these patients, there are a couple of downsides to it, and there are reality checks. One is, these are patients that really want to go back to their community, so now they're on an agent for which their community oncologist may not feel comfortable because of lack of experience. So we need to make sure that the community oncologist, whoever is going to follow that patient locally, feels comfortable and that there is good communication with the transplant center. They are associated with cytopenias, and cytopenias can be severe. What we do know, which I think is good news, is that they're not associated with increased risk of graft versus host disease, although the other medications that they're on need to be carefully monitored for levels. And QT interval also needs to be carefully monitored, particularly when patients are going back on some of the medications that they had stopped previously to go to the transplant.
And I think there is some GI toxicity, and particularly in a patient population where you're worried about toxicity of transplant and monitoring them for chronic graft versus host disease, as well as acute graft versus host disease. There are other, it's difficult to get these patients to stay on the drug. There were a significant number of patients who were not able to complete maintenance therapy. So It's not something where, so there is a value in doing the test to find somebody who is MRD negative, because if you do not need to give them a FLT3 inhibitor maintenance, for maintenance, it does simplify their care.
I think that was a great discussion. So proceeding with the further part of it, I know, so if the same patient decided that he doesn't want to go to transplant, or for reasons, patients run into chemotoxicities, reduction in EF, ejection fraction, or performance status, if the patient does not get transplanted, is there a rationale for continuing FLT3 therapy? And is there a role for oral azacitidine maintenance? So let's look at the data here on that. So, Dr. Luger presented the Quantum First data, and this is their data for patients who are receiving continuation therapy. And if you look at patients who did proceed to transplant, which there was some difference, although not completely statistically significant, but patients in CR not going through an allogeneic transplant in CR1, there was a benefit to giving quizartinib continuation therapy compared to placebo. And this effect was actually seen in patients both who are MRD negative or MRD positive. So the FDA has approved as maintenance monotherapy following consolidation for FLT3-ITD mutated AML to continue quizartinib in someone who is not going for allogenic transplant. This is an abstract that actually Dr. Pearl is going to present, which is showing that at the end of induction, patients who had quizartinib compared to placebo had a longer overall survival. And as I said, benefit seen in both negative and positive patients. There's more data coming on this, interesting. So just drawing your attention to an upcoming presentation. Now, what is the other option here, right? So quizartinib is one option. The second option, which is currently also available in someone who does not go through allogenic stem cell transplant, is oral azacitidine. Quasar study randomized patients to oral azacitidine versus placebo, and this drug was approved for a survival benefit of 24 months versus 14 months for this reason. So what do we do in this patient who has a FLT3 ITD? So let's look at sort of the subgroup for this trial. This is there was a big study. It was not specific to FLT3, but if you look at FLT3 subsets and you look at the mutated FLT3, these are smaller numbers, 30 versus 36 oral AZA versus placebo. Between these subgroups, there was no significance, and also these were smaller numbers. So to me, this means that continuing a FLT3 inhibitor is probably better than switching to an oral azacitidine, but obviously I'll poll my esteemed colleagues on this as well.
Finkel, were these FLT3 ITDs or D835s or a combination of?
I'm sorry?
These FLT3 mutations, were they ITD?
They're ITDs, yeah.
These are ITDs. Yeah, I think in the ITDs, certainly I would prioritize using a FLT3 inhibitor-based therapy as maintenance. And I agree with the previous comments. I think if you don't have the assay, and you say, well, they're MRD negative by 10 to the minus 3 because of flow, that's not enough for me. And so if I don't have the in vivo scribe or whatever assay that gets 10 to the minus 6, I will err on the side of giving them maintenance therapy unless there's some toxic issue that I'm afraid of. Now, I think the D835s pose an interesting question. I think if they're FLT3 D835 isolated alone before and after, do you really use a FLT3 inhibitor post-transplant? Because most of these people are MRD negative, excellent response. I think you can make a case potentially to use oral AZA per the label as sort of intermediate risk maintenance therapy at the time of remission. But again, it's not approved for post-transplant.
Plus for TKD, you would think that the disease biology is probably driven by non-TKD reasons. So, oral azacitidine maybe in that situation is hitting those targets compared to an ITD where you need a FLT3 inhibitor for this. So what are the practical take-home points on maintenance? MRD-positive patients benefit from gilteritinib maintenance in the post-transplant setting. Patients should be considered MRD negative only if they have the right test. So if you have a less sensitive test than 10 raised to the minus 6 and they're positive, obviously that's relevant because they're positive. But if they're negative by the less sensitive test, it doesn't mean that they are MRD negative as long as you have to do a test that is going down to the 10 to the minus 6 level. In patients who are non-transplant patients, survival benefit has been shown for maintenance regardless of MRD status versus in the post-transplant setting where the BORFOR trial showed that its benefit is only in MRD-positive patients.
The question has been asked, do you ever stop FLT3 maintenance therapy, and what do you use for those criteria to make that decision?
You know, as a leukemia doctor, I'm deathly afraid of relapse, and I have difficulty if someone is tolerating a FLT3 inhibitor, and given that all of the trials have given FLT3 inhibitor for a particular time, 24 months, but if someone's tolerating it really well, I actually would continue the FLT3 inhibitor, but obviously if they have tolerance issues, then at least I would try to give for 2 years and then stop.
So can I follow up question maybe for Dr. Geralt? So duration is one thing, but when do you start post-transplant? What's the optimal time to start a post-transplant GILT?
That's an excellent question because a lot of our audience asked the same question at this time. So generally speaking, you wait until, practical purposes, you probably wait until the 3-month mark so that you have the idea of whether that patient is MRD positive or MRD negative. Most of the studies wanted you to start somewhere between 60 and 110 days post-transplant. So again, we have some minutes asking what about, so how long do we give these therapies post-transplant? And the EBMT says 2 years. Do you agree that 2 years post-transplant is appropriate?
I think it should be long. I think the trials were designed, but if you had continued the trial longer, you would have seen the benefit potentially longer too. I personally, even in both situations, maintenance, I personally would not stop as long as they're tolerating okay.
My experience with sorafenib is that nobody was able to tolerate 2 years. Actually with the gilteritinib, I think 2 years is because 80% of the relapses happen during that time, and there is a lot of treatment fatigue. But I agree with you, there are patients in which they are hesitant to stop the maintenance. And anecdote, one of the first patients we ever did azacitidine maintenance post-transplant after a second transplant, I had to convince her after 12 years that it was time to stop because she just simply did not want to stop.
And would MRD testing post-transplant impact your decision?
Only if it were positive, obviously. If that patient was positive at any time post, then I would follow what Pinkal was saying. I would not stop that patient at all, and I would actually consider that patient for potential donor lymphocyte infusions at that time. How about in patients who have not received transplant, who are just after chemo, 2 years, MRD negative continuously, time to stop, or?
I tend to continue. I'm with Pinkal. I think seeing the number of relapses we see when we thought people were cured, I tend to continue. I sort of see analogous to those people with Philadelphia positive ALL who are on a TKI as maintenance therapy forever, a very long time, unless there's some toxicity or financial issues. I think I tend to continue.
Yeah.
But I guess what we have with pH positive is a very good test, and hopefully that's what we're going to have now. If we have sensitive assays that would tell us that consistently it's MRD negative, we would feel better about stopping. But I would be very nervous without a GVL to stop FLT3 inhibitor in someone, just in remission because of the combination plus FLT3.
I think we all have anecdotal patients who've needed to stop because of toxicity, who were MRD negative, and we're keeping our fingers crossed, and it's gone in both directions. And so I think at this point, we don't really know which patients are safe to stop in. The GVL effect does give us some additional benefit, but in the non-transplant patient, we just don't have that.
Yeah.
So one of the things that's asked is, how often do you repeat FLT3 mutation analysis, and is it superfluous to repeat the test in patients who've relapsed?
Yeah, very good question. FLT3 can be acquired, can be lost. There's different ITDs. There's acquiring ITD plus TKD that would change your management. So I would continue monitoring with MRD testing and FLT3 after that with NGS. Ideally, if we have an NGS that would tell us what is the ITD and tell us the degree of MRD, that would be best in my opinion.
So I would say that someone who has turned negative at this point, since we don't really have an obvious treatment, unless you're thinking about DLI, in which case you'll probably also see some chimerism change. Someone who's turned negative post-transplant or post-standard therapy, I probably wouldn't continue to monitor MRD testing unless I saw a change in their blood counts, because I don't know, we don't really have a standard therapy for that patient population if they're already on a FLT3 inhibitor. And similarly, if someone is MRD positive, I think I would want to know if that person turns MRD negative. And so I think I would continue to follow them, because if their numbers were to go up, I might want to intervene with some more aggressive therapy, because I think MRD positivity is active disease. I don't think MRD is disease that's going to stay quiet. I think if somebody has MRD positive disease, it's just a matter of time before they have clinically.
So you're saying the intervention at time of MRD positive is not going to be different than intervention at morphologic relapse?
Mm-hmm.
So so we talked about patients who can tolerate intensive chemotherapy. What if our patient was actually a 78-year-old man with newly diagnosed AML, older age, comorbid conditions, like COPD? This patient, again, presents with a 55,000 white cell count, same numbers, but now we have an older patient with comorbid condition. What is the role of FLT3 chemo sparing, or whatever, the non-intensive, which is a little bit of in the eye of the beholder, but non-chemo, traditional 7 and 3 based chemo regimens. So the standard in this situation, as we all know, is azacitidine and venetoclax. The VIALE-A study randomized patients with newly diagnosed patients, older, aza-ven versus azacitidine, and this was approved because of survival benefit at 24 months, 38 versus 7. CR/CRi was 65% in the ven-aza group versus 23% in the azacitidine group. So if you look at this study and look at FLT3 TKD versus ITD, the TKD data looks pretty similar to the overall population with a CR rate of 77%. If you look at FLT3 ITD, although the CR rates are the same, 63 here, 65 here, if we look at the median overall survival, this is very much different and lower, and there's no significant advantage over azacitidine and placebo. So we think that this, there's no FLT3 inhibitor here, which is obvious, and there may be resistance mechanisms that venetoclax cannot overcome. So what are we doing to improve the backbone of these therapies? So there's the first one is a triplet with azacitidine, venetoclax, and gilteritinib. This is a trial that was presented by Nick Schwartz from MD Anderson. We have to be careful about the triplets because there is significant cytopenias that are associated with these regimens, and the way venetoclax and gilteritinib is dosed is very different. So if you look at here, azacitidine is given standard dose and induction, 1 to 7. Venetoclax standard ramp up and then 400 milligrams, but stopped at 14 days. Gilteritinib 80 milligram given again for 14 days and stopped. And what happens, and the way the trial was designed, is there's a day 14 marrow. And if the blasts were more than 5% with cellularity more than 10%, then you continue it, both drugs, because azacitidine is over by then. Venetoclax and gilt is continued, and repeat marrow is done 7, 10, 14 days later to see. And in consolidation, the doses were further reduced. Azacitidine now for 5 days, venetoclax for 7 days, and gilteritinib now is continued continuously through day 1 through 28. And this showed a very impressive response rate here in the ITD population and the TKD population. The 6-month overall survival, 100, 100, and the 1-year overall survival for the TKD was 100%, 79% for the ITD population, with the CR plus CRI of 96%. Again, time to neutrophil recovery, more than 500 is a bit delayed, 37 days, and same for platelets, which is a little bit better. What are the other FLT3 triplets? Decitabine, venetoclax, and quizartinib. This is an abstract, which is again going to be presented on Saturday at ASH. This again, I'm only going to look at the frontline patients. These were 10 patients, complete remission rate of 100%, and they did a pretty similar, day 14 analysis. 30 and 60-day mortality was 0. 40% of these went on to go to transplant. When we're thinking of these triplets, obviously the dosing duration and response is very, very important. You really have to, there's some caveats. So first is, better to start venetoclax when the white cell count's under 10, because otherwise the tumor lysis is pretty robust and you end up having a lot of toxicity. And very important to do day 14 marrow. And then on day 28, it's important to do another marrow to confirm that somebody is in remission. If they are in remission and they still have cytopenia, so basically no leukemia, sort of but hypocellular marrow or normocellular marrow, but blast count is low, then you really have to consider GCSF for the ANC, and also stop the gilteritinib to allow for platelet recovery to happen. And same thing for the maintenance, for the subsequent cycles. It is already dose reduced to begin with, but it's an active management based on how they're doing to appropriately dose reduce. So one of the questions, what would you do if someone is in getting this therapy in remission and they're still having cytopenias? Is there a strategy to dose reduce, or is it patient specific? How do you practically do this with guilt, Ben?
Yeah, absolutely. I think like you said, I think the key is patient specific, right? So every patient is a little bit different. You see how they tolerate what they're responding to. I think you showed the great data there with the DAC-VEN quiz and the AZA-VEN quiz, guilt. I think one of the things we forget or don't realize is that there is a lot of sort of close monitoring that goes behind it. I think that we used to start with 28 days or 21 days of VEN and full dose guilt the entire time. And over time, we learned that indeed that was too much. There are drug-drug interactions that cause significant myelosuppression. And so the current approach has been, what we got to is 14 days of VEN, 14 days of gilteritinib, potentially at a lower dose of 80 milligrams. And then as we go forward, and as you mentioned, during consolidation, even with AZA-VEN for that matter, it doesn't have to be AZA-VEN guilt, but the more cycles you get of these therapies with venetoclax and HMA, what you'll see is more and more cytopenias. The same is what we see with this combination. And so over time, we'll do these things. We'll reduce even further the number of days of venetoclax, the number of days of gilteritinib. Occasionally, we have taken off the venetoclax and just continue with an HMA and guilt or guilt alone, those patients who are frail and who are very prolonged myelosuppression. And again, a lot of this is also based on their level of disease. We'll kind of do surveillance marrows to make sure that their MRD is low, that their FLT3 is undetectable. So these are the kind of approaches. But I think it's an individualized approach, risk adapted, to see what's going on with their disease. Oh. All right. Good afternoon, everyone. Thanks for coming. Thanks for being here. This is a huge group, and I'm really happy to be here with my esteemed colleagues today. So we're going to talk today about, you learned all about FLT3, and so there will be an examination at the end, so make sure you take notes on the FLT3 section. My part, no exam. So we're going to talk about older patients who are presenting without targetable mutations, right? So the classic patient where we give HMA and venetoclax, those who are unfit for intensive chemotherapy, who are maybe 75 years or older, or even younger than 75, but where you do not want to give intensive chemotherapy. So let's start off with a case, as we have done with the others. So we have an older patient, 76-year-old male, John, with newly diagnosed AML, presents with weakness, fatigue, bruising, shortness of breath, exertion. Performance status is 1. He has comorbidities, hypertension, diabetes, coronary artery disease. He has acute myeloid leukemia, white count 9.5, ANC is low, thrombocytopenia, 45% circulating blast. There's his karyotype, somewhat complex, 5q, trisomy 8, 12p. Notably, no 17p. Okay, maybe monosomal, but you don't see that. And then you look at the mutations. What you see is his mutations in ASXL1, SRSF2, TET2. Maybe he had some CML prior, who knows. But notably, the FLT3 is wild type, P53 is wild type, NRAS is wild type. So the discussion, is aza-ven the optimal next step? And what do the NGS results tell us about the likely efficacy of Ven-Aza platform? So think about that. I'm going to poll one of my colleagues here. Anything, just a really quick bite on this, Gus? Anything about this that strikes you as interesting?
Well, I don't see any clear cause of resistance to venetoclax, and I think this is a patient that should get standard of care, which is HMA venetoclax.
Okay. Good. So I like how you're thinking. You're looking at, well, what can cause resistance in this patient? And we'll get to see that in a few slides. P53, complex karyotype, may predict for resistance. Things like NPM1, IDH1/2 may predict for sensitivity to HMA ven-based therapy. Great question. Now, if venetoclax therapy is initiated, what are the best practices in addressing neutropenia? Now, we'll get to this, but I also want to hear some of the colleagues across the nation about how we treat and how we sort of manage neutropenia in these patients. Because, you know, I've been asked many times, is aza-ven intensive chemotherapy, right? The label says, no, it's low-intensity therapy. But I say, well, it's both, right? It's intensive in the setting that it does cause severe myelosuppression, reminiscent of what we see with 7 and 3 or intensive chemotherapy. It's potentially less intensive because we don't see maybe the mucositis, the GI toxicity, the hair loss, sort of the extramedullary toxicity. So I turn to my colleagues. Dr. Luger, what are the best practices, would you say, to address neutropenia when you see that in your patients with HMA and ven?
So I think what you brought up earlier is really important. Therapies really needs to be individualized here. Although it's not like when we give single agent azacitidine where we just start on day 29 for cycle 2. The patient needs to be assessed at various time points. And you need to assess their blood counts, their response, how they're tolerating it, and really make patient individual decisions every cycle. There's not a simple one decision you can make for a patient at any given time that will be durable, nor can you assume that any patient's going to respond the way a different patient did.
Absolutely. Going up the East Coast a little bit to Cornell, Dr. Desai?
Yeah, I think I agree totally. We always, at 21 days, would stop the venetoclax and assess for a bone marrow. If the patient, if the marrow looks ablated, there's no residual disease, then I tend to give GCSF immediately in order to have count recovery. Unless there's obviously leftover disease, then we would continue the venetoclax a bit longer. Absolutely.
Okay, another twist. The same patient, now a little younger, 70 years old, white count's a little higher, 10,000 white count, AML M5. You guys remember M5 from medical school? Because we don't use it anymore. M5, right? Monocytic AML. Like we said, oh, FAB is gone now, but it actually isn't. There's some data suggesting that monocytic AML may potentially not respond as well to HMA and venetoclax. So AML M5 by FAB, a little higher white count, pancytopenic, but has mutations in NRAS, DNMT3A, SRSF2, TET2. Would you consider venetoclax with other backbones? Have you heard of other studies? For example, we have a study with clad-LDAC-ven, which may be potentially active in these subtypes which are resistant or maybe don't respond as well to HMA and venetoclax in the front line. And this is not an uncommon patient. We frequently see patients who are post-CMML who become AML M5 or who have NRAS mutations. So we'll get into that a little bit. And then finally, what if this patient was 40 years old, right? Newly diagnosed patient 40, are you going to use HMA-ven in this person? Is there an opportunity to add venetoclax to more intensive backbones? We've seen this starting with folks like Andrew Wei from Australia, 5+2, the FLAG-IDA regimen, the CLIA-ven regimen. The Chinese have a 7+3 plus venetoclax. The Italians are using it. So this is potentially part of our future as we move to improve therapy in acute myeloid leukemia. How do we incorporate ven not only into HMA, but into other backbones? Those patients who are potentially in the middle, where you kind of don't want to give them intensive chemotherapy, but maybe a little more potent therapy, or those people who are younger, how can we lift their survival curves to even better than what they are? So what are the current options for patients who are ineligible for intensive chemotherapy? These are the NCCN guidelines. These are things that we often refer to. HMA-ven category 1, phase 3 evidence of survival benefit. Decitabine has also been used with venetoclax, and there are other recommended ones that you have seen before: Galastagib plus lotus-IRC, LDAC plus venetoclax, single-agent AZA or decitabine. But we have a host of options. These days, more and more I've seen patients are using HMA, or physicians are using HMA and venetoclax in their patients. And clearly, this has been a revolution in our treatment of older patients with AML, right? The addition of venetoclax to azacitidine has significantly improved response rates. From CR/CRi rates we used to see in the range of 25 to 30%, 65% response rate overall in our patient population. We're actually now able to get these people in remission, and in that certain subset who is still eligible for transplant, get them to allogeneic stem cell transplant. And for the first time in a very long time, we have a frontline therapy that's improved overall survival in older patients with newly diagnosed AML. With the survival seen there, and I think Pinkel showed this, 14.7 months versus 9.6 months in newly diagnosed AML. This particular slide outlines the update with Keith Pratt, showing that over time, the survival curves are still apart, so there's still a survival advantage, but as you get farther and farther out, that survival long-term goes down to 25 to 30%. So what's wrong? What's going on here? Why are we not getting better results? Why are we not seeing the plateau? What can we do to optimize our approach with HMA and venetoclax, or venetoclax in general? Can we do some different things? Can we dig deeper and figure out how we can better incorporate venetoclax? So what was the toxicity with venetoclax and AZA? We know neutropenia, febrile neutropenia, cytopenias. We see that, as I mentioned before, intensive on the marrow, less intensive on everything else, but we do see cytopenias, and this is one of the dangers as we try treating these patients outpatient. They need to follow up, they need to take their antibiotics, they need to get G-CSF if their counts are low. We need to shorten the days, duration, and dose of the AZA and the venetoclax as we treat these patients going forward. And as I go through this talk, we're going to have a little discussion on how we do that in these centers, of how we reduce these doses to mitigate the risk of neutropenia and the risk of death from these infections. So one of the abstracts that was presented a year ago at ASH was by Donor and colleagues. And what they did is they went back to the Viale ACE study. They looked at those patients and said, you know what, the ELN 2017, the ELN 2022 classification system doesn't really stratify patients very well when you're giving them HMA-Ven. It reminds us that stratification has to do with what kind of therapy you give, and that's for intensive chemotherapy. So they came up with their own system using just mutational data. And that's actually, you can see on the screen far away, it's a perfect and a very beautiful segregation of different types of risk in AML who are treated with AZA and venetoclax. And they used just 3 mutations: FLT3-ITD, NRAS or KRAS, I call that one mutation, and P53. If you had none of those mutations, you were on the top curve, you did the best with HMA venetoclax. If you had a P53 mutation, you were on the bottom curve. You did the worst with HMA venetoclax. If you had either RAS or FLT3 or both, you were sort of in that intermediate group where you sort of benefited maybe from HMA and venetoclax. So very nice segregation just by using 3 mutations in your newly diagnosed patients with AML. They went a little further. They looked at each different group, so-called the higher benefit group, which is the top curve, the intermediate benefit, and the lower benefit group, right, the P53s. And what they found in the higher benefit group, those with no mutations, they had a significant survival advantage with the addition of Ven to azacitidine. On the right side, in the lower benefit group, no benefit to the addition of venetoclax to azacitidine among those patients with P53 mutated AML. Let's look at the intermediate group, though. Those patients who had FLT3-ITD mutated AML, or those patients who had RAS mutations, there was no significant survival benefit with the addition of Ven to azacitidine. So the FLT3, you just had a beautiful lecture about what we can do in those folks, potentially do triplet medications, optimize that, give triplet therapy in the future. But what about those patients with RAS mutations? Is there something that we can do with patients with newly diagnosed AML who have RAS mutations to optimize their therapy, potentially with different backbones? The other option is, what do we need to do to have practical advice of how we manage our patients with HMA and venetoclax? So this is a little schematic that kind of goes through our approach to treating patients with HMA and venetoclax. We start both therapies concomitantly on day 1. When do we start therapies? We don't start therapies when their white count is 15 to 20,000. We try to cyto reduce them. We get their white count usually below 15, below 10 optimally. Among those patients who are NPM1 mutated, IDH1/2 mutated, very sensitive disease, very high risk of tumor lysis syndrome. So in those patients, cytoreduce, we ramp up the venetoclax dosing, usually over 3 days, not over a week like we do with CLL, but over 3 days, and start the venetoclax on day 1 along with the azacitidine. Additionally, we give antimicrobial prophylaxis. Now, the culture may be different across institutions, but our goal is the same, to make sure that these patients have low risk of infections, low risk of readmissions. So we try to give antimicrobial prophylaxis, and occasionally that includes azoles, including voriconazole, posaconazole, strong CYP3A4 inhibitors that require dose adjustments of venetoclax. Transfusion support in between while they're cytopenic, and how many days of venetoclax do we give? So often, and we do this all in our institutions, we do an early bone marrow, usually around day 21, 25, to see what their blast count looks like at the time when they're most cytopenic. If there are no blasts at the day 21 bone marrow, we stop venetoclax at week 3 or 3 weeks into it, instead of giving the full label dose of 28 days, and allow that last week for hematopoietic recovery if they're going into remission. We see that, and that has actually mitigated a lot of the dosing issues in neutropenia. If they are in morphologic remission and they're taking a long time to recover, we often delay the cycle for 1 or 2 weeks and then use G-CSF as long as they're in remission in subsequent cycles to make sure that we mitigate their risk of neutropenic fever, infection, sepsis, and hospitalizations. There are studies actually looking at modified dosing schedule and efficacy. This is a study by Keith Pratz, and the way you should read this is from the top down. Looking at all those patients with Ven-Aza, 185 patients with Ven-Aza achieved complete remission, CR, CRh. 24 of those patients, just 24, had no issues with grade 4 thrombocytopenias. The rest, 161, had at least one episode of grade 4 cytopenia during their course. 31 of those patients died or came off study, left the study. 59 of those patients had an immediate dose reduction down to 21 days out of 28 days for their next cycle of chemotherapy, okay? So had cytopenia, next cycle only 21 days. The 71 other patients had cytopenias, but they continued on venetoclax full dose, and they had a later cyto reduction after multiple episodes of cytopenias. So what they call this is early dropping of the dose and late dropping of the dose. And you can see the survival curves on the bottom. I don't need to tell you about them, but they're overlapping, suggesting that giving 21 days or an early dose reduction of venetoclax versus a late dose reduction, giving more cycles with 28 days of venetoclax, had no impact on survival. There's also a very interesting abstract at this ASH, Saturday, tomorrow afternoon, in the AML oral session, which actually looks at from the French group, among those patients who had aza-ven and got toxicity for whatever reason and stopped venetoclax. What were their outcomes compared to those patients who continued venetoclax? You'll be surprised to see the results are very similar. And among those patients who stopped and then restarted the venetoclax, you can see that they still responded, albeit at a lower rate. So I encourage you to check out that session. It's an interesting abstract. Finally, the French group also looked at a retrospective study looking at just 7 days of venetoclax. Wow, right? Blasphemy. What happened to 28 days? So instead of giving 28 days, they looked at some patients in their own retrospective, again, off clinical trial, who patients said, look, you're really frail. We're just going to give you 7 days of Ven and 7 days of Aza. Let's see what happens. And so they did that, and you can see here in a retrospective single arm, kind of look at this, the median overall survival 12.8 months in these patients compared to 14.7 months in the VIALE-A, EFS of 7.5 months, and their CR/CR rate very similar to what you saw in VIALE-A. So is there a room, is there an opportunity to reduce the number of days of Ven while still maintaining excellent response and emphasizing safety? And I think there is, and we'll talk about that as well more. All right, what about combining venetoclax with other backbones? We've talked about HMA a lot, we talked about Aza, low-dose ARC, has a great response rate, but what about going a little bit more intensive? I talked about these subsets like RAS or FLT3 or monocytic AML. Is there another backbone that we can use? We've done some work at MD Anderson with a combination of cladribine, low-dose ARC, venetoclax, or clad-LDAC, or cladelac, we like to call it sometimes, with venetoclax in newly diagnosed AML. It's 5 days of cladribine at 5 per meter squared IV, and then just sub-Q low-dose cytarabine, 20 BID sub-Q under the skin for 10 days, low-intensity therapy, no anthracycline, no high-dose cytarabine, and venetoclax during cycle 1 for 21 days. If you achieve a complete remission MRD negative, cycle 2 and beyond, you only get 7 days. If you achieve MRD positive remission, cycle 2, you get 14 days. So that's how we designed this study for newly diagnosed patients 16 over with acute myeloid leukemia. And what we found, this was published, and we have an update now at this ASH. I encourage you to check it out, 123 patients. But this is 60 patients, CR/CR rate 93%, CR rate 80%. 84% of those patients had MRD negativity at the time of complete remission. So very high response rates, 1 and 2 year survival listed there. As a step up, a patient potential improvement in outcomes over HMA-Ven in a single arm study in patients with a median age of 69 years. So potentially an interesting backbone. Why is it also interesting? We then looked at subgroups. We saw this data in RAS, in this intermediate subgroup. What about RAS mutations among patients who receive clad-LDAC? The response rate among patients with RAS mutations, 84% in that trial, and the median survival listed here of almost 2 years. Median survival in those RAS mutated patients with a 2 year survival of 60%, better than what you saw in the VIALE-A study. We then went back and looked at all of our RAS patients with RAS mutated AML and said, what is the best therapy for patients with newly diagnosed AML who have RAS mutations? The best therapy clearly is intensive chemotherapy. And this mirrors a lot of the study, a lot of the work done by Claire Bloomfield and others. We're looking at high-dose ARC as consolidation for RAS mutated AML, but intensive chemotherapy appears to be the best. HMA-Ven is the middle, and on the right is the clad-LDAC-Ven, and we found that the overall survival long-term was better, again, comparing different groups, but better and potentially superior in these RAS mutated groups. And clearly on the right side, you can see that the response rates are significantly higher with this backbone. So maybe there's a subset of patients, those with RAS mutated AML, newly diagnosed older, they may not benefit as much from HMA-Ven. Can we consider a new backbone for that patient population? What about monocytic AML? So this is work done by the Colorado group, Dan Pollier, Craig Jordan, and his colleagues, where they made an observation several years ago among their patients treated with HMA venetoclax, and they noticed that among those patients who had M5, monocytic disease, that they saw generally lower response rates and low outcomes. And in fact, those patients were enriched for RAS mutations, and those patients had upregulated MCL1. And so HMA-VEN may not be the best strategy. In a series of basic science papers, what they found is that they saw that AML is composed of a few different types of stem cells, what they call leukemic stem cells and monocytic stem cells. And among those patients who have a monocytic type phenotype, AML M5, that actually the best drug in their screen was a nucleoside analog known as cladribine, a drug that we've been using as well in our low intensity program. So maybe cladribine can also be effective in this monocytic subtype AML M5. So as we look at these, as we study this a bit more, do more research as the drugs get approved, we start slicing, dicing our patients into different categories by subtype, by mutation, by morphology, and others to potentially provide them the best optimal therapy. And so we're now looking at cladribine low-dose specifically in this monocytic population to see if we can improve those outcomes, get the remission rates up, and improve survival in this difficult subset. What about intensive chemotherapy? I've been kind of teasing you about this, but we've used intensive chemotherapy with venetoclax in our newly diagnosed patients for several years at MD Anderson, initially with FLAG-IDA and venetoclax, as well as CLIA and venetoclax. And you say, well, that's crazy, right? That's a lot of intensive therapy plus venetoclax, but we don't give 28 days of venetoclax, and I'll get to that in a minute. But the response rates, the CR rate, 80 to 90% with the combination of ven and intensive chemotherapy with high rates of MRD negativity in a younger patient population with a median age around 45 to 50 years. What did we see? Why did we do this, right? The question is, well, why do you want to give ven with intensive chemotherapy? What benefit are you getting? Now, the randomized trial hasn't happened yet. We don't know if it will. Maybe 7 and 3 plus or minus ven. But we looked back at our own experience with FLAG-IDA and CLIA without venetoclax and compared it to CLIA or FLAG-IDA with venetoclax. And what we found is two important things. Among those patients who had intermediate risk disease and adverse risk disease, we had significantly higher rates of complete remission, significantly higher rates of MRD negativity, and many more patients getting to allogeneic stem cell transplant, and a significantly lower rate of death in that patient population. So our approach or our interpretation of this is that among those patients who are intermediate adverse risk, except for those who are P53 mutated, the addition of ven to intensive chemotherapy may improve the ability or their predicted outcome to get to complete remission and get to allogeneic stem cell transplant, potentially improving that cure rate in these patient population. And these are the survival curves on the left, intermediate, and on the right, adverse risk AML. Now, as I mentioned at the top of the talk, this has been done by many different groups. You see CLIA-VEN, FLAG-IDA-VEN, FLY-VEN, which is from Italy, 5+2 venetoclax from Australia, 7 and 3 ven from China, and CPX-VEN also at our institution. And you can see in that number of days of venetoclax, 7, 14, 20, 14, 8, 7. So I think this is where the research is looking into about how do we optimize therapy with intensive chemotherapy and venetoclax. Clearly, 28 days is not the answer. 7 seems to be enough when you give it with intensive chemotherapy. The Chinese study does a very interesting wrinkle. They give venetoclax with induction only, with the 7 and 3, and then it just give high-dose cytarabine alone as consolidation. This may be an approach that may be viable because, in fact, although we see very few cytopenias during cycle 1, meaning that their counts recover by day 28 in almost 100% of patients, it's on subsequent cycles, cycle 2, cycle 3, where we do see that prolonged myelosuppression. What if we were to omit venetoclax on subsequent cycles? So these are some of the questions that we're asking in how to optimize the use of venetoclax as we go to the next step in the future. And I think this is going to be part of our future going forward. So I'll recap and I'll do some take-home points right here. I think that we all agree that HMA-VEN has really revolutionized our approach in our treatment of older patients with newly diagnosed AML, but we can optimize it further. We need to really talk about adjusting the dosing of venetoclax, and I'm going to ask my colleagues their opinions and their approaches. Again, we can all learn from each other. We need to look at alternative lower intensity backbones. The clad-LDAC-VEN is just one, but many others are being developed where we add venetoclax not just to HMA or low-dose ARC, but other low intensity backbones. And how about adding venetoclax to intensive chemotherapy? Higher rates of MRD negative CR is what we've seen, higher rates of stem cell, low rates of relapse, and then fewer days of venetoclax. So I'll turn to you guys, and I think if you look at the 3 cases, just as a recap, in that 76-year-old newly diagnosed AML who had no signaling mutations, no P53, I think it's a reasonable approach to use HMA venetoclax. In that second patient who had the RAS mutation, maybe a little bit younger, M5 by FAB morphology, can we use a cladribine-ven regimen? That would be my approach. And then in a younger patient, certainly I would prioritize ven and CLIA as our initial induction in the hospital with full support. So guys, I want to turn it over to you. I've been doing a lot of talking. We'll start with maybe Dr. Luger. Dr. Luger, any advice on days of venetoclax, growth factors, antimicrobials? What's your approach?
So I think, so the first cycle of a patient in whom I'm considering aza-ven, I do some similarly. So we do a marrow between day 21 and 25. If the marrow shows no evidence of disease, we stop the venetoclax, and we wait for up to 14 days to allow count recovery, and we will give GCSF support to promote that recovery, particularly if their platelets have already recovered, and hope that they can start within 2 weeks. We do not use antifungal prophylaxis in our first cycle in a patient who has no concern for fungal disease in the newly diagnosed patient. If they do need to have antifungal treatment, and I would say it's not prophylaxis in that patient population, then we'll dose adjust our venetoclax accordingly for that patient.
Sorry, go ahead. Sorry.
I think the goal in many of the, in our 76-year-old, our goal is to get them into a remission and then to allow them to maintain that remission with as few cytopenias as possible as time goes forward. And so it's going to be really adjusting their doses, adjusting the duration on a cycle-by-cycle basis. My general thinking is if I can get the cycle in within about 6 weeks with my current dosing schedule, I maintain it. It's rare that I give more than 21-day cycles, 21 days of venetoclax and subsequent cycles, and I'm quick to decrease them to 14 if they are having cytopenias that make them go more than 6 weeks between cycles. So that's kind of my general approach to the upfront patient.
Do you ever touch the AZA? And do you go even less than 14 days for ven and AZA in your patients?
So in someone who has post-remission, we're talking about post-remission, obviously. So I universally start with 5 days of azacitidine. I do not give 7 days post-remission. And the venetoclax, most of the time, I would actually give 14 days and see what happens with that, because that seems to keep the patients at that 6-week mark. I agree, I keep that 6-week cycle going. And depending then on how much cytopenias they have, I've actually gone down further, 7 days of venetoclax, that's like the next step. Beyond that, I've even gone to 3 days. I've gone to 3 days of HMA. But the goal is you want to give a cycle every 6 weeks and whatever, gets you there. And we actually always give azoles during induction with HMA and venetoclax. Obviously not during the ramp-up phase, but once there is, we do appropriate dose reductions. But that's interesting how everybody does.
So what I'm hearing, it's okay to give less than 28 days of venetoclax.
Yes.
Is that right with HMA and Dr. Issa, tell me about GCSF. Do you never use it in AML? Isn't that?
I do.
Oh.
I like it. Yeah.
Yeah.
So
tell me about how you use it and when should we use it?
So there's a specific question that I asked the group, but what makes me hesitate sometimes is MRD positive. So any blast less than 5% at day 21 is a consideration for GCSF. Sometimes I take nuances based on the genotype. So NPM1, IDH are incredibly sensitive, so I'm less hesitant about stimulating MRD. For other mutations where I feel like the depth of remission could be jeopardized and they're not at risk of infection, I don't always use GCSF.
Okay.
Maybe it's different on the fourth floor.
Yeah.
Can I ask you 2 questions?
Absolutely.
My 2 questions for you are, do you ever decrease the dose rather than the duration of venetoclax when there are cytopenias? And do you ever stop therapy completely in a patient who's in remission?
Yeah, great questions. Okay, so number 1, do I ever decrease the dose of venetoclax? I only decrease it if I'm using concomitant azoles or other CYP3 inhibitors or diltiazem, which I know will increase the levels. We actually did a study looking at ven levels on different azoles, and what we found is actually, the labeled dose of venetoclax with posaconazole is 70. We found that 70 actually probably was too much, and we go down to 50 in those. So that's the only time I reduce the dose of ven. I usually use the number of days as my sort of rheostat, if you will, for cytopenias. The second question was, do I ever stop therapy? I mean, I get nervous about stopping therapy. So in my intensive chemo-treated patients who go to transplant, they get post-transplant maintenance. in my intensive chemo who don't get transplant, I give them actually some sort of maintenance therapy afterwards. At around 24 months is what we've talked about arbitrarily as our number of when I may stop therapy. In those low intensity patients who are older, who are receiving HMA-VEN as their ongoing therapy, I will stop when they sort of get some sort of toxicity or are unwilling to proceed further. I'll do a lot of cutting of the doses until I get to that. Sorry.
What if they're IDH and NPM1 mutated and achieve an MRD negative response?
Beautiful question. So if they're IDH mutated or IDH 1 and 2, again, I'm one of these who likes to continue therapy. I often, and cytopenia is usually the reason why I need to stop, is if they're IDH 1 or 2 mutated, I may switch them actually to an oral ivosidenib or enasidenib based on their mutation, sort of as a maintenance therapy. I see much less cytopenia, better tolerability, particularly if their IDH mutation is still present. In the NPM1s, there's a place where I think I would, in some cases, stop therapy and observe. We don't yet have the next-gen sequencing level of MRD testing for NPM1. Once we get that, I'll be much more comfortable with just saying 6 cycles and we're going to stop. And then, you know stuff about the bone marrow, right, Dr. Geralt?
I have no clue what you're talking about.
All right, so thank you.
Thank you. So actually, it's a great segue to talk about. Right? So although not mentioned, all these patients are transplant eligible. And full disclosure, I'm a transplanter. I have no conflict of interest there. So I'm going to touch base on treatment refractory AML and the role of transplant. And presenting a case, a 68-year-old has a secondary AML presented with treatment refractory disease. I'm going to actually say this patient had myeloma because this is a curveball I'm going to send to my colleagues. And then developed MDS, and then went on to get CPX351. But she decided not to pursue transplant at that time. She was treated with venetoclax decitabine until progression, and then she had 12% blast at the time of progression and had a 12 out of 12 unrelated donor. So the question comes up is, should she receive salvage therapy and should we transplant this patient? So should she receive salvage therapy? So this brings last year's plenary session presentation, which many of you we were left, I would think, with, it was very thought-provoking. This was the ASAP trial presented by the German group, in which patients with AML, 18 to 75, who either had a poor response to induction therapy or were untreated relapse and had an HLA-compatible donor and were fit for intensive chemotherapy salvage or an allogeneic transplant, were randomized to 2 strategies. One was a disease control strategy in which patients would be watched and only being given low-dose Ara-C or mitoxantrone at low doses to control the counts. And once ready, they would go on to proceed to a sequential conditioning regimen with Flamza followed by RIC, or high-dose melphalan followed by a low-dose flu-TBI regimen. Or they would be randomized to a standard remission induction with mitoxantrone Ara-C, and then proceed to an allogeneic transplant. And I think what surprised us all was that there was no difference in leukemia-free survival at day 56, which was the primary endpoint, amongst patients who were treated with standard induction versus those who were simply treated with, or say, disease control or count controlling chemotherapy, and then went on to transplant as soon as possible. And the median follow-up was now more than 3 years. So the conclusions were patients with poor response after induction or relapse AML do not benefit from salvage chemotherapy with high-dose Ara-C and anthracycline. Watchful waiting and sequential conditioning prior to allotransplant results in comparable CR rates. Patients would spend less time in the hospital if they with the disease control strategy rather than with the remission induction strategy. The impact of morphological CR at the time of allotransplant was less important than expected. And minimal disease burden at the time of admission for transplant is not a prerequisite for long-term disease control. And the benefit of any treatment aimed at better long-term control by inducing a CR prior to transplant needs to be demonstrated in prospective trials. So there are a lot of issues that we had, and many of us, when we went back to our centers, people said, well, based on the ASAP trial, we should just take them straight to transplant. But the ASAP trial didn't include hypomethylating agents, venetoclax, as salvage. And the reality is that we wish we had such close monitoring of patients that we could immediately proceed to transplant within 4 to 6 weeks. That's generally not the situation that we have. And many times we just learn about these patients at the time of relapse, and no donor has been identified. So although one of the conclusions was that impact of achieving CR to salvage was not clearly demonstrated, when you look at the manuscript and we look at the data, patients who achieved the CR on the remission induction group did significantly better than everybody else. So it wasn't powered to answer that question. But if we had strategies that could achieve complete remission, those would immediately impact outcomes. The other things that was not presented in ASAP was, what if these patients had IDH mutations? What if they had FLT3 mutations? How would that change your strategy of, oh no, I'm just going to take them straight to transplant? You would probably try to reinduce them. And we really didn't have a feel of what the total denominator was. So, and then the other thing is that, the group in the UK had done the study of FLAMSA-BU versus just straight, regular transplant. There was no difference in doing one of these sequential conditioning regimens. So that makes the applicability, and I think the ASAP study was excellent. I think it really is. The one thing that makes the ASAP study very important for us in the United States, it shows how important it is that there is a close communication between the leukemia physician taking care of the patient and the transplant physicians who will have to decide when to take the patient to transplant. And I cannot underscore enough of how important it is to have a donor already identified, particularly at the time and date today where everybody has a donor. So should she be transplanted? So she had 12% blast, let's say after salvage. And the reality is that many centers across the world would not transplant her. Outcomes are dismal. Why would we expose the donor to risk when benefit of the patient is doubtful? Even if they achieve a CR, it won't make that much of a difference. There's no easy way to transplant. There are no clinical trials for these patients. And it might hurt my results in the stem cell transplant outcome database. And the last one is actually not true. That's actually going to be presented here at ASH in the health outcomes research, and I invite each and every one of you to look at that. There are now clinical trials for these patients, as we'll see. And I think, one of the things that when we talk about dismal results is the reality is these patients without a transplant, their expected survival is less than 18 months. And that actually 20% of these patients can achieve long-term disease control. This is, CIBMTR data. And this is both with a related and an unrelated donor. So yes, the outcomes are not great. 50% of these patients are already relapsed within the first year. And this is standard conditioning regimens. But the reality is that, and not all relapse patients are the same. This is a paper that's now more than 13 years old, was published by Dr. Duval, and it looked at, is there a way that we can categorize patients with active disease? And he developed the Duval score. And basically, if you don't have peripheral blood blasts, if you have a good performance status and a good donor, even if you have active disease, your progression-free survival is more than 40%. So there are patients who can do really well. And just because they have active disease, we should not be denying them a chance to transplant. I want you to focus on the 6%. Those are patients who had peripheral blood blasts and high blast counts in the bone marrow. And I want you to see this, that patients, you still can get around 40% of the patients alive and in remission at the 3-month mark. And why is that landmark important? It's important because the outcomes of patients who are alive and in remission after 3 months who were transplanted with active disease is totally different. There's still, yes, there's a high relapse rate, especially during the first 2 years, but not everybody relapses. So that, trying to have strategies that will get patients in remissions that will last at least 3 months, durable complete remissions, is an important outcome. So if you also look at the way people relapse, there are those who relapse early. What strategy can we use to try to improve their outcomes? And those are patients that we have to have better conditioning regimens. What we do before day 0 will make a difference for those patients. But many of the patients relapse between day 60 and 100. So what can we do for those patients? We need to be able to intervene early. And you saw the impact of FLT3 inhibition. What can we do for patients who are the late relapsers? And one of the big challenges is that there are even patients who we consider at low risk for relapse because there's less than a 15% chance. Trying to develop strategies for them is difficult because trying to do randomized trials in patients who only have a 15% risk of relapse is almost impossible to do. So the randomized trials have to be done in patients who have risks of 30 to 50%. These are all the different strategies that we can do. I'm going to focus somewhat on the preparative regimens. And the first, this is actually, and as I hear, what we talk about venetoclax, exposure is important. And until recently, we've been given busulfan at a fixed dose. And Bori Anderson, MD Anderson, with the development of intravenous busulfan showed exposure is important. That if you actually do PK-directed exposure, you can have a significant impact in progression-free survival for patients not in remission, but more importantly for patients not in remission. Look at the difference between those that got PK-adjusted busulfan. Now, currently, the only drug we adjust for is busulfan. At Memorial, Dr. Gunjan Shah and I have been working on trying to do the same thing for melphalan, which is the most common reduced-intensity conditioning regimen together with fludarabine busulfan. The other one is targeted radioimmunotherapy. So here, we know that increasing the dose of radiation can reduce the risk of relapse, albeit at increasing the risk of toxicity. So is there a way that we can deliver high doses of radiation to the marrow without increasing toxicity to extramedullary sites? Apamistamab is an anti-CD45 monoclonal antibody conjugated to radioactive iodine that was designed to deliver targeted myeloablative radiation to hematopoietic cells along with the reduced intensity conditioning prior to allotransplant. And this was presented last year as a late-breaking abstract. This is the phase 3 Sierra trial in which patients with active relapse refractory myeloma, so they either had to have peripheral blood blast or more than 5% blast and be over the age of 55. Not your ideal candidate for transplant, correct? They were randomized to get apamistamab or conventional care. And after apamistamab, they would proceed to get a fludarabine low-dose TBI containing allogeneic and conditioning regimen followed by an allogeneic transplant. And the primary endpoint here was a durable complete remission. Patients in the conventional care arm, if they achieved a complete remission, they could either continue on maintenance or go to a standard allogeneic transplant based on physician preference. This is more so patients got a dosimetric dose and then a therapeutic dose, and then they went on to get fludarabine TBI if they were randomized to the apamistamab arm. Now, importantly, patients in the conventional care arm who failed to achieve a remission were allowed to cross over and get apamistamab, but they had already achieved the primary endpoint of relapse. These are the patient characteristics. I'm not going to go over them. They were similar across the groups. And amongst the patient who crossed over, that was 44 out of the 77 patients randomized to conventional care crossed over to apamistamab. Again, but I want to show you a couple of things. One is percentage of blasts, 30%. And many of these patients had peripheral blood blasts. And if you remember the Duval score, that was 6%. So durable complete remission. So first, 44% of the patients getting IOMAB-B achieved a complete remission, only 4 in the conventional care arm. 13 or 22% of the patients in the apamistamab arm were able to achieve a complete remission that lasted more than 6 months. And again, remember what I showed you with the importance of having a complete remission that lasted 3 months. And this is what the survival curves look like. So patients in the crossover and in the IOMAB-B, many of them, again, and these are, by no stretch of the imagination you're going to say, oh, this is good. No, but this is much better than what the control did and serves as a building block or as a stepping stone to improving of these outcomes of these patients. So median overall survival in the crossover cohort was 7.7 months. The crossover cohort survival 1 year was 35%. And I think the main message here is whether you received apamistamab as initial therapy or as a crossover, you did much better than had you never received apamistamab. More importantly, of the patients who achieved durable complete remission, those durable complete remissions are ongoing. And actually, Dr. Yogurtsa has one of her patients is now 4 years out. So very well tolerated, again, in this older group of patients with, toxicity rates that are comparable, if not better. The one important one was significantly less mucositis. So the conclusions of this in patients over the age of 55 with active relapse and refractory AML, apamistamab followed by a RIC was associated with a rate of durable complete remission more than 6 months that was higher than conventional care, and that's resulted in a significant benefit in progression-free survival. And this is a novel solution for this group of patients who in many cases would not be considered for an allogeneic transplant. In this meeting, the data from the Sierra trial in patients with p53 mutations will be presented, and again showing a benefit for patients with a p53 mutated leukemia getting apamistamab followed by fludarabine and low-dose TBI. Remember, these patients were not allowed to receive maintenance therapy unless they were FLT3 mutated. We will also hear about another way of conditioning patients without the standard high-dose alkylating regimens, and this is briquilimab, which is an antibody drug conjugate. Briquilimab is an anti-c-KIT antibody, inhibits stem cell factor binding to CD117. It depletes progenitor cells. It is being investigated in combination with standard non-myeloablative regimen using fludarabine and low-dose TBI. This was presented last year at ASH. This is, again, similar strategy. So they get the briquilimab, which is actually a naked antibody, followed by fludarabine and low-dose TBI. Tacrolimus, sirolimus, and MMF was the GVHD prophylaxis. This was what presented last year at ASH. This will be updated this year in the Saturday session. So what about maintenance? And again, you heard all about targeted maintenance with FLT3. There are other targeted strategies that can be used. What about non-targeted approaches such as hypomethylating agents, donor lymphocyte infusions? These have the potential of being more toxic, but they also have the potential of avoiding resistance through the natural mechanisms of losing the target. There is a randomized trial for hypomethylating agents that was performed by Dr. Batul Aran at MD Anderson that did not show a benefit. However, that trial had its issues. We are anxiously awaiting the results of the Amadeus trial that's being performed by Dr. Charles Craddock in the UK, looking at oral azacitidine as maintenance. So before we go to Dr. Issa's presentation, I think I want to conclude saying, we are now at a time that we can actually, and we should actually consider transplant patients with active disease. I'm going to go back to the patient I presented and ask my colleagues. This is a patient who transformed after having received induction therapy for myeloma and being in a complete remission. She actually has cells in the freezer, and she now has severe cytopenias after induction. Would you give those cells back? Do you ask before you start induction?
Ask if you have cells left?
Ask if you have cells in the freezer.
No, I always ask transplanters after that. They say, oh no.
So, and I bring this. This is again. See, this is a rare occurrence, but not extremely rare. And I recently had a patient of mine who returned back to their local physician, developed acute leukemia, was going through induction, and I'm getting called back that she had not seen a white cell in 3 weeks. And marrow was empty. And I said, well, right. And we actually did give her cells back, and she recovered, and we were able to bridge her to transplant. But it brought this idea that, I'm also, patients should probably have a med alert badge that if you're thinking of giving intensive chemotherapy and those cells are available in the freezer, we can easily check them for the abnormality. Up to now, the experience is that they won't have that clone, and you will make them recover within 10 days. So you can save them the severe cytopenia.
Quick questions before we move on. People are asking whether you can compare epamistamab to TBI, and if there are settings other than refractory disease where you consider using epamistamab.
So those are great questions. So actually, epamistamab can deliver up to 12 gray of TBI of radiation to the marrow. So it is even higher levels of radiation to the marrow. So it's different than TBI because it delivers high doses of radiation specifically to the marrow space while sparing normal organs. We do want to explore epamistamab in other situations, particularly for younger patients in remission or in combinations with other reduced intensity conditioning platforms. And I know we are in the process of planning those studies, and hopefully we will see further evaluation and with modern maintenance strategies. Thank you very much. And now, to close us off, Dr. Issa will talk to us about new developments in. I did not know that MLL is now KMT2R.
Thank you, Dr. Giral. Yeah, so every time I talk about it, I have to remind everyone that this was MLL.
The disease known as MLL before, right?
And now it's KMT2A. I had to tell my boss for the past 2 years that it's changed. Okay. So we'll start with the case. This is a 60-year-old man who has KMT2A rearranged leukemia. This is a typical translocation. So KMT2A is on the 11q23 locus. So 911 is a typical translocation in AML. And this patient has received 7+3 transplant and then relapsed, had AZA/VEN. What is the expected prognosis given testing results and treatment history? Maybe I'll ask TAP. How bad is MLL?
So MLL, I think, is very bad. I think the technical term. I think very adverse prognosis. We sometimes say that the 911s may be a bit more intermediate, but I think that all MLLs are probably very adverse risk. It's interesting. I think they respond well to chemotherapy. It's that they all relapse. Yeah. I think that's my impression.
Yeah, I agree. And as a footnote, so the ELN has 911 as intermediate, but the ELN was developed based on high-intensity treatment and age less than 60. So if you take all patients, that difference is not significant between 911 and other MLL translocations, and it certainly should not be a reassuring factor. So in the frontline setting, any MLL should get transplant. Then in this setting now, what standard options can be considered, and what is the role of menin inhibitors? So I'll take you through that. I'll talk to you about this new therapy, menin inhibitors. Before we get to that, so KMT2A specifically has higher risk of mortality, especially during induction. This is a study we've done at MD Anderson. And this could be related to this monocytic phenotype that TAP was referring to, but something also specific about KMT2A. There's a higher risk of DIC. So when we looked at causes of mortality compared to diploid karyotype, KMT2A has higher rate of mortality, almost double. And the majority of death are related to DIC or organ infiltrate. Sometimes this would be DAH or respiratory failure. So typically we give them high-dose chemo and suddenly they're intubated, they're on pressors, and that could be really challenging. So one thing I would recommend, and there are some studies about that, is the use of steroids when there's leukocytosis or leukostasis. Now this study was in all AML. This is a retrospective analysis from France that showed benefit of giving high-dose steroids during induction of AML. But I would say this is specifically applicable to KMT2A rearranged leukemias, where it may mitigate the risk of ARDS and DAH that may happen with it. So the target of menin inhibitors for now is KMT2A rearranged leukemias, and we're also using it for NPM1 mutant leukemias, and I'll explain why. So KMT2A rearranged leukemias, previously known as MLL, are translocations that involve the 11q23 locus. They're about 5 to 10% in incidence across all leukemias, but this is really a leukemia that happens from infants to children to adults. So for example, KMT2A rearranged leukemia form 80% of infant leukemias. And there's variability by the fusion partner. So there are some that confer an AML phenotype versus ALL. Whereas NPM1, the other target for menin inhibitors, is the most common genetic alteration in AML. And what's common about these both genetic alterations that they cause the same abnormal gene expression that causes leukemia, and menin inhibits that. Menin inhibitors inhibit that gene expression. Despite all progress in AML, KMT2A rearranged leukemias still have a 5-year overall survival of less than 25%. So there's more to be done. So there are many menin inhibitors in development. So as a recap, menin inhibitors are small molecule inhibitors. They disrupt the binding of KMT2A to menin, and that machinery is what's critical to cause the gene expression that causes leukemia. So these are pills that would disrupt the binding. This is the stage of each of these menin inhibitors in development. The revumenib and ziftomenib are the furthest ahead, and we're going to hear this ASH about all of them, I think, in the upcoming meeting. So revumenib specifically here is that pill. So it binds a pocket within KMT2A, and it disrupts the binding of KMT2A to menin, but all menin inhibitors fit that pocket. And when they disassemble this complex, it downregulates HOX and MACE. These are the genes that are responsible for the differentiation block in these leukemias. So this leads to a differentiation effect and eventually turning the cells back into normal and an anti-leukemic effect. So this was the theory behind menin inhibitors. It took 30 years of science, and this is the phase 1 study of revumenib, Augment 101. So revumenib is like venetoclax. It's affected by CYP3A. So CYP3A inhibition increases levels of revumenib. That's why we investigated it in 2 separate arms. Arm A had no strong CYP3A inhibitors, whereas Arm B had strong CYP3A inhibitors. So these are POSA or VORI, for example. And we did dose escalation. There was dose-limiting toxicity, which was a QTc prolongation. Then we stepped down in the dose, and we reached a recommended phase 2 dose in both arms. We saw an anti-leukemic activity in this phase 1. I'll take you through this data. So this is the summary of the data that was just published last year. These patients were heavily pretreated. We treated infants as young as 1 year old up until age 79. The majority were AML, but we included AML, ALL, or mixed phenotype. And they were heavily pretreated. The median number of lines of prior therapy was 4. Half have had venetoclax or transplants. The majority were KMT2A, and about 20% were NPM1. The main side effects that we saw with revumenib were QTc prolongation. 10% had grade 3 QTc prolongation, but no patient had grade 4, in other words, serious arrhythmia or had to stop the drug because of QTc prolongation. The other notable side effect is differentiation syndrome. In this phase 1 study, it was observed in 16%. It was not severe. So this is similar to IDH inhibitors or ATRA or arsenic. And it resolved with steroids or hydrea if there was leukocytosis. Other common but non-severe side effects are nausea or vomiting in about 20% of the cases. But what's exciting is that we saw significant anti-leukemic activity. So in this heavily pretreated cohort, we saw an overall response rate. So these are blast reduction to less than 5% in 53% of the cases. And the complete remission or complete remission with partial hematologic recovery was 30%. And excitingly, the MRD negative rate was 78%. So to my knowledge, this is the highest response rate with a monotherapy in KMT2A rearranged leukemia we've seen. And the responses, although are in small sample size, were similar between KMT2A or NPM1 mutant leukemia in this cohort. These responses were mostly durable. There was a companion paper that came up with this that talked about resistance. And interestingly, the mechanism of resistance is the binding site of the menin inhibitors. So those mutations disrupt binding of the menin inhibitors and lead to relapse. You may view it as, the fate of any targeted therapy, but it also tells us that we've hit an important target, because this justifies the mechanism that KMT2A menin interaction is critical for this. Despite the resistance, there are some patients that have remained in remission at the time of data cutoff up to 1.5 years or 2 years. But the median duration of response was 9.1 months. So after the phase 1 was complete, the phase 2 study started. This was designed in separate cohorts, all pivotal, meaning that they were designed to lead to registration of the drug and FDA approval. There was a KMT2A rearranged cohort and NPM1 mutant cohort. The primary endpoint in this analysis was CR/CRh, so similar in design to what's happened with the IDH inhibitors, for example. And now we have results from the KMT2A rearranged cohort. This will be the late-breaking abstract session that's going to be presented by my colleague, Dr. Aldos. So the study met the primary endpoint, which was efficacy. So we saw a rate of complete remission with partial hematologic recovery, about 22%. So this is within the bounds of what we saw in phase 1 and exceeded our null hypothesis in the design. And therefore, the study was stopped because of this efficacy, and we're now filing for FDA approval. We also saw a high overall response rate. So there was a 63% overall response rate, and the MRD negative rate again was high. 70% of these cases had MRD negative. About 40% of the patients moved on to a transplant. So all these indicate that we've achieved meaningful clinical benefit with these patients, and these are multiply refractory patients that have responded to this therapy. So the next steps of revumenib are currently combination studies. There are multiple combination studies on the way. Tomorrow morning, I'm going to be presenting our study at MD Anderson, SAVE, which is the combination of SNDX-5613 or revumenib with Astellas, so oral decitabine and venetoclax. There's the BEAT AML study, which is AZA, Ven, revumenib. There's also a combination study with chemotherapy, so fludarabine, cytarabine, and revumenib, and there are multiple other studies that are planned with revumenib. So the other menin inhibitors that's furthest along the way is ziftomenib. So this is also a small molecule inhibitor that disrupts the binding of KMT2A and menin. Same mechanism, it leads to downregulation of those genes that cause the differentiation effect. And so HOX and MACE are what's critical. The COMET-01, which was the ziftomenib phase 1 study, had a slightly different design. So this drug is once a day, revumenib is twice a day. Ziftomenib is not affected by CYP3A. And in the dose escalation with ziftomenib, at first there was no specified genotype, so KMT2A or NPM1. Everyone was included on the study. And then in the phase 1b expansion, we only focused on NPM1 and KMT2A in 2 doses, 200 milligrams, 600 milligrams, and then we identified a recommended phase 2 dose in NPM1, which was 600 milligrams. And I'll take you through this data. So this is a summary that was presented by Dr. Fathi last EHA on the data specifically on NPM1. Again, these are patients that are heavily pretreated. The median age was 70, so also slight difference here. The age of enrollment was 18 and above, and they have the usual co-mutations that we see, such as FLT3 or IDH mutations. The majority of patients had a response, and I'm going to go through it now. So these are the side effects that were seen. We also saw differentiation syndrome. So this is an on-target effect that happened in about 20% of the cases. There were no QTc prolongations. And the differentiation syndrome in here, there was a grade 3 differentiation syndrome. And in fact, we had higher grade differentiation syndrome that led to those 2 doses that we chose, 200 milligrams, 600 milligrams. But importantly, we also saw high response rate. So this is the NPM1 cohort. In this cohort, we had a complete remission, or CRC, composite complete remission of 35%, and CR/CRh was 35%. This is a great monotherapy for NPM1. We saw recovery of counts, such as platelets and ANC, like you can see in this diagram. And in a small sample size, there didn't seem to be any difference in responses by co-mutation status, so FLT3 or IDH. The median time to response with revumenib is 51 days. So just remember that this is an epigenetic therapy, so it takes a little longer for patients to respond, but we've had excellent responses. This is the swimmer's plot that shows that these responses were durable. The median duration of response was 8.2 months. There were 2 patients that moved to transplant and 1 that started maintenance post-transplant. So the next step with ziftomenib are to combine it, and these are also some of the studies that are going to be in combination. So there's the pivotal study that's going to be in NPM1 is still enrolling. That's COMET-001. COMET-007 is testing it in combination with intensive chemo or Aza-Ven, and then the COMET-008 is testing it with FLAG-IDA, low-dose cytarabine, or gilteritinib. So in my opinion, all of these are exciting combinations for these specific genotypes. So to recap on this specific case and on menin inhibition, the data on menin inhibition is promising. It shows that we can target these genotypes with a therapy that reverses abnormal gene expression in specific susceptible leukemias. I've mentioned the example of NPM1, KMT2A, but there could be another or a few other rare subtypes of leukemia that may respond to menin inhibitor, but are dependent on the same gene expression, HOX and MACE. The next steps are to combine menin inhibitors with current standard therapies for KMT2A. Right now, in my opinion, if we go back to that case, if someone has multiply refractory KMT2A rearranged leukemias, their best chance of response is to enroll on a menin inhibitor study. Outcomes with chemotherapy are simply not good. In the future, the things that we need to do is improve biomarkers to identify patients that may respond and improve biomarkers for disease detection. And then maybe the next generation of menin inhibitors could work on overcoming MEN1 mutations, which are so far the main mechanism of resistance identified. Okay.
So there's a question for you regarding the application of menin inhibitors in KMT2A mutated AML with co-mutations. How does the presence of co-mutations impact your decision about menin inhibitors?
So in KMT2A rearranged leukemias, I think the impact of co-mutations is minimal. First, let's just start by stating that KMT2A rearranged leukemias have the fewest co-mutations among AML. If you look at the TCGA data, there's like small box at the end that says KMT2A, and that's because the fusion is so potent to cause leukemia, it's almost the only event. And whenever there's a co-mutation, in 20% is FLT3 or RAS, and a small sample size that we've looked at in either the revumenib data, FLT3 co-mutation or RAS co-mutation did not affect response to menin inhibition.
So we have 10 minutes for questions. There are microphones there, and I'm going to have my co-moderator to go over the questions in the chat and see what we can answer.
So I have a question for you, and what is the role of MRD testing prior to transplant? So what MRD testing do you look for? Do you expect MRD to be done in all AML patients, and if so, what type?
So I think the main role of MRD testing, particularly in patients with intermediate or favorable risk acute leukemia, is to help inform a patient whether to proceed to transplant and to inform the transplant team whether that patient should receive some form of post-transplant therapy as maintenance. And we actually do both flow and NGS. The data emerges that if you're positive for flow and NGS, your risk of relapse is extremely high. If you're positive for only one of the 2 measurements of MRD, it's intermediate. And if you're negative and if you have intermediate risk disease, particularly if you're less than a, we'll say, optimal transplant candidate, you may consider delay in transplant or hoping that you will not relapse and continue on some form of post-induction maintenance strategy.
I have a couple questions for you, and is there ever a role for really low dose hypomethylating agents? And in an IDH mutated patient, how do you decide when you should use aza-ven versus using a IDH inhibitor?
Yeah, so great question. I think the really low dose HMA. So as I said, when I'm using HMA-VEN, as I go on further cycles beyond 4, 5, 7, 10, 12 cycles, I often do what Dr. Desai talked about earlier by reducing the number of days of VEN, but I also reduce the dose. I'll go down from 75 to 50 per meter squared. I've used AZA post-transplant in the maintenance setting among when people don't have any options on clinical trials or they're not FLT3 mutated. There's a dose that Dr. Marcos de Lima used of 37.5 milligrams for 5 days. That's the dose I use. There's also a study being done at Montefiore, Albert Einstein, where they're using actually a weekly dosing of HMA with decitabine. So decitabine once a week, maybe with venetoclax, ultra low dosing. I'm curious to learn about the update of that trial, so that's another approach. But that's when I would use really low dose. In maintenance, we're using a 50 per meter squared for 5 days every 4 weeks. And then the second question was about, I forgot. IDH, right. So if you look at the, so there's lots of ways of looking at this. If you look at the outcomes of IDH1 and IDH2 mutated AML on VLAA, they're excellent, right? So if you lump them all together, high rates of response, 70, 80%, and their outcomes, their survival is excellent. It's actually better than 14.7 months. When you split the two out, what you notice is that the IDH2 actually do much better than the IDH1 mutated. Is that because of the biology of IDH1 mutated AML? Maybe VEN is not as active in IDH1, we're not sure. But then, in contrast to that, again, comparing across trials, you have the AGILE trial showing that the combination of AZA plus ivosidenib showed a dramatic overall survival benefit with a median survival of 24.5 months. And so in my practice, if I had those two options in the IDH1 mutated newly diagnosed AML, I may sort of opt for using Ivo-AZA, whereas if it was IDH2, I would be comfortable using AZA venetoclax. Although I think either AZA-ven is probably a good option in either one of those patients.
Thank you. Dr. Desai, there's a question about oral azacitidine maintenance. Is that something you'd ever consider doing as a maintenance therapy in a patient who's had induction with aza-ven?
No. So first of all, oral azacitidine is pharmacokinetically different as an HMA compared to what we traditionally give azacitidine subcutaneous or IV. And the way the data are, HMA when needs to be continued, and that's how these trials were run. I would be uncomfortable with the maintenance strategy. If somebody got HMA venetoclax as their induction strategy, you would continue that. The only reason somebody might consider switching is that they have tox from HMA-ven, but I would say that there's actually very good strategies to reduce cytopenias by just reducing the HMA-ven. So I would not use oral AZA as a maintenance post-HMA-ven.
So I have a question for you. If you're monitoring a patient, let's say off maintenance therapy, and suddenly they become FLT3 or MRD positive, would you immediately send that patient to transplant, or how would you approach that? I'll start with you, Dr. Lugar.
So if you look at the old transplant data, the old data suggests that if you take someone to transplant in early relapse, you do just as well as you do by giving them salvage therapy. Now that is also before the era of lower intensity therapies that allow us to get somebody. So I think my general approach is to try to give them something to try to decrease their disease burden before going to transplant, or at least do that while I'm trying to find them a donor, would be my general approach, something to decrease that burden of disease.
Yeah, I would agree. We would try to, usually take some time to get to transplant anyways, and you can sneak in something that would make them MRD negative perhaps before they would proceed to transplant. Obviously, the Australian Intercepts trial is currently running and asking that question, that is early intervention going to matter or help, but that would be the approach. I agree with Dr. Lugar.
And not to put you on the spot, when do you When do you get the transplanter involved?
Immediately, so I mean, I would, as soon as I find the MRD, I would let them know that this patient is about to relapse. So if there is any, donor search that was suspended or the donor search happened a while ago, they update the search, and they're usually seeing the transplanter in that month. If I'm giving them some sort of MRD eradication strategy, they're seeing them during that month. So if we get to the point where everything works out well, they're ready to go.
Okay. Tapan and Gus, how many cycles of Veneza or low-intense regimens do you recommend before taking a patient to transplant?
I don't think there's a specific number. I do want to get them in remission. And typically, my practice is to consult stem cell transplant usually very early on, maybe a couple of days into the diagnosis. So that process about getting an unrelated donor is starting. I would say, on average, probably a median cycle of 3 to 4 cycles before going to transplant, but there's no specific number. It's best response and when they're ready for transplant.
You want to do one more question?
I'm just going to ask you another question from the audience about MLL. Do we always find KMT2A rearrangements on karyotype, or do we need to do some other form of testing?
Yeah, good question. So I'd say 95% it's evident on conventional cytogenetics. So these would be translocations that involve the 11q23 locus. But I would always recommend confirming with another test. So the most widely used is FISH. And in the 5% of cases that we call cryptic, so these would be not evident on cytogenetics, but so the breakpoints were small, not picked up on cytogenetics. These can be picked up by RNA-seq or FISH, or maybe one day whole genome sequencing.
And as we're waiting for these MLL, these KMT2A inhibitors to be available to us, and we're in between studies, what is your approach to the patient with KMT2A relapse disease?
Yeah, so there's a recent publication in Blood on decitabine venetoclax that showed that, in fact, responses with HMA-VEN are not great with KMT2A. And we have our experience, the study that TAP has led at MD Anderson, CLIA-VEN, and FLAG-IDA-VEN, showing almost 100% response in KMT2A rearranged. So my impression, KMT2A rearrangements are rare, is that they do better with cytarabine-based high-intensity chemo plus venetoclax, obviously, if we can deliver that therapy.
So with that, and I want to, once again, on behalf of all of us, thank you for staying to the end and for coming to this session.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MQE860. This activity is supported by independent educational grants from AbbVie, Actinium Pharmaceuticals, Astellas, Kura Oncology Incorporated, and Syndax.